Good morning, respected chairpersons, uh, friends, colleagues, peers, seniors. It's a pleasant day today, and it's an honor for me to be standing before you today to give you this introduction to CHIP, and also introducing a small CHIP toolbox, which will prove to be effective when dealing with patients with CHIP. This conference has been so designed to bring out all the different facets of CHIP, looking not just at the complexity of the cases, but also focusing on the risk aspect of it, and also to ensure that these are indicated procedures and to ensure safety while addressing this very high risk subset. So as you all know, we know that CHIP stands for complex, high or higher risk indicated patients and procedures. It was derived to identify the subset of patients who are at high risk, has complex disease, but can benefit greatly from intervention by an experienced team with a specific program designed to succeed in this subset. So these are the different aspects of CHIP that we will need to look at. So how do we identify the risk and the complexity? There are three factors. As you all know, coronary anatomy is the basic one. We also have other non-coronary concomitant cardiac disease, and in addition, we also have the comorbid conditions that the patients might present with. So looking at coronary anatomy, you have different complex subsets, the chronic total occlusions, left main, bifurcation, trifurcation, or even quadrification, calcified lesions, long lesions, multivessel disease, and of course, combinations of all the above. Associated cardiac conditions may include structural heart disease, valvular heart disease, arrhythmias, poor LV function, hemodynamic instability, heart failure, and combinations of all of them. Other patient comorbidities that may interfere with successful CHIP procedures include advanced age, chronic malnutrition, frailty. Now, frailty has become a very important key factor, so we need to look at frailty very, very closely. Diabetes, hypertension, dysmetabolic state, especially if uncontrolled. Renal disease, always a problem for the interventionist. Liver disease because of the associated bleeding problems. Vascular disease, other vascular disease, limiting access, producing vascular complications, and again, combinations of all of them. So all these procedures, despite the complexity and the high risk, need to be indicated. So we need a heart team approach involving a team of professional individuals, patient-centric discussion, multidisciplinary team meet, indications, appropriateness of the procedure should be discussed, identified, and action taken appropriately. You need to discuss the risk of the procedure versus the perceived benefit from the procedure. You need to clearly document that this could be the benefit or these are the likely benefits of an advanced, complex, high-risk procedure. Costs are definitely a concern in India, and of course an informed consent from not just the patient but also the patient's close relatives will be a must. So coming to the toolbox, I'll be very brief. First, we have the equipment and the hardware. You need a high-end cath lab with radiation reducing or radiation protection features because all these procedures take a long time. High resolution imaging, display monitors which can show very high resolution images will be key, especially when we perform very fine coronary work. Hybrid lab facilities are always a boon because some of the access might need to be surgical, some of them may be a combined surgery plus interventional procedure to give you the best possible results. Imaging and physiology, we are looking at it again today evening. FFR, IVUS, and OCT will help to optimize all the results to know where to go, when to go, and how to go. When there is hemodynamic instability, you need support in the form of intra-aortic balloon pump, Impella, or the ECMO. The costs are an issue. Again, we have a dedicated session looking at mechanical circulatory support in CHIP. Echo and TE guidance are often useful. You need a dedicated anesthesia station so that these patients are safely taken care of while the complex procedure is going on. Defibrillator and emergency cart is a must in any cath lab anyway. And you need storage in lab, refrigerator in lab to keep the necessary medicines safe and effective. So this is just about the equipment and the hardware. You need to look at the personnel. At the head of the team, you need an experienced interventional cardiologist who is familiar with chip, who is capable and skilled at doing the chip procedures. You need a hard team approach with a long list of associated people. So the different specialties depend on the exact problems that the patient may have. The cath lab team is the backbone of any chip procedures. So the primary operator, the assistant, the scrub nurse, the techs, circulating nurses, anesthetists, and the techs, all of these are very vital cogs when we deliver chip service. The intensive care following a chip procedure is also equally important. Many a time, the patient is lost not because of the intervention, but because of the poor care that is delivered post-intervention. So the post-intervention care is also equally important. And all the supportive teams and staff should be on their feet and should be well clued to what is going on and should be contributing their bit. Looking at the hardware, again, this hardware should be available in any cath lab that is deciding to go for chip. So looking at the guidings, you need an active guiding support when you deal with complex patients. So this is an example where you have an active guiding support which takes support either from the coronary cusp or from the other wall of the aorta so that you can perform interventions. You might even need a coronary guide extension. So guide extension may come in different types. You have the guide liner, the guide on telescope, guide Scylla, and you have the guide +2. So all these things will be again discussed later in different sessions. I'm just giving a brief outlook of all the things that need to be there. Again, guide wires are plenty. Again, you need to know your guide wire. You know to know what exactly is the guide wire that you need. The choice of the guide wire depends on the lesion. You have different types, the workhorse guide wire, the polymer jacketed guide wire, which may be soft, non-tapered, soft tapered, or a stiff one. You have the stiff guide wires without polymers. You have the support guide wires, which are of extreme importance, especially when you deal with calcific lesions and difficult to guide hardware situations. Atherectomy wires. You need external wires in case of retrograde approach to CTO. Pressure wires, that is also a type of guide wire. There are different types again. So you need to be familiar with some or most of these wires and know how to use them. Microcatheters may be single lumen or double lumen. They may serve a general purpose of delivering the hardware, exchanging wires. You can have channel dilators, which may be antegrade or retrograde and antegrade. You have calcific lesions which need specific microlumen with microcatheters like the turnpike. You can have some angled microcatheters which are of niche use, low profile catheters. Again, these are some of the microcatheters in different use. Of course, you have the Supercross family of microcatheters with angled tips for navigating complex anatomy. You have some newer microcatheters in the form of the center cross and the multi-cross, which will help you in specific situations. Double lumen catheters, you have the Crusade, which is commonly available now, but again, there are other dual lumen catheters which are coming in, like the Sasuke. Of course, at the end of procedure, if you want a perfectly interventional approach, you need to close large bore access many a time with vascular closure devices. These are some of the devices that are available, the ProGlide, the AngioSeal, and the Obtura device. So this also could be of help. The other hardware, I'm not going into the details, the balloons, you need very small small diameter balloons like 0.75 millimeter and 1 millimeter balloons, which are of use in crossing CTO lesions, very large diameter, especially for the left main. When you have a 5 millimeter or a 6 millimeter size left main, you need an appropriate size balloon. Non-compliant balloons are a necessity. Cutting and scored balloons have their use in calcific lesions, osteal lesions. High pressure balloons are sometimes needed again in calcific lesions. Stent balloons, again, sometimes it's worthwhile to keep stent balloons handy so that not just the use as a balloon, but also for measurement of the length of the lesion. Covered stents are a must. Thrombus aspiration is again an issue. because thrombus often is a great enemy of complex interventions. Rotablation, intravascular lithotripsy, other niche devices like the Stingray, Crosspost, Tornus, and now laser has made an entry into the coronary intervention field with use in instant restenosis, thrombotic lesions, crossing uncrossable lesions, etc. It's always useful to have a toolkit with all this hardware ready and assembled into a cart. The chip cart will often be very useful when you have an urgent demand, an emergency demand. At that time, you don't need to go running around searching for hardware. Thank you for your patient listening.
Now the term chip is slowly getting established among the interventional community. I think in India, a few years ago, Dr. Ashok Seth has initiated in Delhi a few meetings, and now in Kerala, the present team under the guidance of Dr. Anil Kumar, he said in 2019 there was a short meeting, in-house meeting in Astor Hospital. Now I think this is the first event in Kerala which is happening in a very structured way of dealing with this chip interventions in cardiology. Now when we say chip, you have been doing this sort of cases for the last so many years. Perhaps not from a point of view of looking of this terminology of complex high-risk indicated PCA. But I think all of us are doing, and as Varma has pointed out, you should have essential skilled people in the lab, essential facilities, support facilities, and all these things. But now what is we should look forward to is to have a clear definition for those patients who are coming under this group. He has said patient-related factors, procedure-related factors, and all that as high risk. But still, we don't have a clear definition so as to we can assess whether what we are doing is really required for the patient and what is the outcome. What the data is available only is on the pre-discharge outcome. We don't have a long-term or a short-term outcome of chip patients who have been done. Just like we have a lot of scoring systems for other multi-vessel disease, we have some DAT score which is established all over the world. So I think that is what one should look forward to have in the chip cases. So at the end of this meeting, we will go through all the complexities of the procedures, but we should go home with an idea that this comes under a chip group, so that we have to prognosticate, we have to discuss with the patient and the relatives what we are going to do and what we are going to expect out of the procedure. I think that is very essential for dealing with this sort of cases. This will be my comment on this topic. I think, Sekhar.
Thank you, sir. Varma sir, it was a very nice talk. And the point I would like to highlight in addition to what sir said is like I am fortunate to be part of a big team of interventionists in Amrita Institute of Medical Sciences for the last 16 years. And can't agree more on the role of having a good team approach for such patients. I would say in addition to the team which sir has already shown in one of his slides, more than one interventional cardiologist would be a very good option for each case. At least two cardiologists per case, because it is tiring. We get radiated more. Thought processes may not be, we all know that when there is a complication, all of us don't think in the right way. Some of us might slip few points, so our senior colleague, friend, whoever is there with us will say, no, let's do that. So that usually saves the patient. And as sir said, definitely this subset of patients, how they are doing in the long run, time has to tell us, and we have to collect data for which inter-institutional we will have to work across Kerala and see what our data would be like in future. Thank you.
Hello. Dr. Varma, wonderful program and a nice talk. As Dr. Sarita mentioned that you need more than one interventionalist in the room, which is absolutely essential, especially for CHIP, because you are under high pressure and you need to make a lot of critical decisions. And I think with the advent of Impella and other mechanical support devices, I think the outlook for CHIP is much better, and I'm sure we're going to hear more of that today. Thank you.